Madam?
Yes, when you're ready, you can.
Okay, so we can start now.
Sure,
Okay.
sure. Is everyone back?
I think everybody back.
And when you're ready, share screen.
Just want to introduce you a little bit. Everybody maybe know you, but as Dr. Kylie is having from Australia, she is with us from morning, and she is Senior Research Fellow, Senior Lecturer, Burns and Injury Research Unit, School of Biomedical Science, Faculty of Medicine, and Director of Skin Integrated Research Institute at the University of Western Australia. And Dr. Kylie have Board Wounds Australia Adjunct Research Fellow, School of Anatomy, Physiology and Human Biology, UWA, and Senior Research Associate St. John's of Good God Hospital, Midland, Western Australia. Dr. Kylie is a research scientist based at St. John God Hospital, Midland, Adjunct Research Fellow, School of Human Science. Her research experience include clinical trial design and implementation, ethics, and governance, key stakeholder relationship management, methodology, data management, analysis, and dissemination of findings. She is currently principal investigator of several trials in the wound care arena, and she has recognized for her research in March 2018 by receiving the Journal of Wound Care Based Clinical Research Award for her doctoral work. And she also received third place in innovation in surgical site infection in 2018. Her primary teaching and research interests are translation research, prevention of surgical wound complication, skin integrity, and health service outcome. And she is also the chairman of Board of Wound Australia, member of Finance and Audit Subcommittee, council member of European Wound Management Association, international board of member of World Union of Wound Healing Societies. Dr. Kylie is recently co-chaired the WUWHS International Consensus Document on Surgical Wound Dehiscence, a direct result for her doctoral work. Dr. Kylie is co-editor of EWMA International Consensus Document on SSI Improved Healing Outcomes and was a member of Journal of Wound Care Consciousness Document, identifying and treating foot ulcers in patients with diabetes, saving feet, legs, and lives. Madam, now the stage is yours.
Thank you.
Welcome, madam.
Thank you for the lovely introduction. And I'm just trying to find where I share my screen. There we go. Okay. And can you see that okay?
Yes.
All right. So now I need to go to full screen. Just going to do this for the moment. There we go. Just bear with me. Okay, here we go. Thank you so much for the lovely introduction. Quite a long one. I hope we're all still awake. We've got a cup of coffee and we've had a refreshing break. I'm delighted to join you this afternoon. I'd like to say thank you to Professor Sandeep and Professor Hari Krishnan Nair and Lincoln University and the Malaysian Wound Care Society of Professionals to join you this afternoon in your wound management workshop. I've heard some great talks today and some really exciting information. So I'm learning just as much as you are as well. I'd love to hear more stories about Hari and maggots and also wound therapy. So hopefully in the not too distant future, we can all get together and share our wound healing stories. So for today's presentation, I'd like to talk to you about surgical wound complications. So we'll work through a definition. We'll also look at recognition or recognising surgical wound complication risk factors, how we identify these and how we report them. We'll look at how we assess skin integrity in terms of the surgical wound and look at the principles of acute wound management. I'll also talk a little bit about evidence for prevention and go through a recent best practice statement that was published through IceCap, and also introduce you to a new surgical wound dehiscence grading system that you can implement in clinical practice. And of course, hopefully we'll have some time for some questions and answers. Did you know that there's an estimated 313 million surgeries conducted around the globe every year? That is a considerable amount of surgery happening. When one creates an incision, normal wound healing trajectory usually occurs within 72 hours post the insult or post the injury, with 6 to 8 weeks for full wound closure. And of course, all things being equal, we're dealing with the ideal patient without any complications. However, they do occur. Complications such as an infection or dehiscence may or may not be related to several phases of the patient's surgical journey. So that's intraoperative, preoperative and postoperative factors. And we need to really examine how these factors contribute to post-wound healing. The most commonly reported time frame for a surgical wound complication is usually day 7 to day 9 after the procedure. However, it can also be reported up to and including 30 days and also 90 days if patients have had implants such as hip or knee. Surgical wound complications are more commonly managed in the community nursing setting. However, well, that's in Australia and Europe. However, every country is different. So some patients may return to the acute care setting, or some may be managed in primary health care with general physicians, or may even be looked after by a nurse practitioner. It really depends upon where you're from and what your practices are in your respective regions. But most importantly, we need to define what a surgical wound complication is. And an internationally derived decision or consensus-derived definition was found following a IceCap, or an International Surgical Wound Complications Advisory Panel meeting, of which Prof. Hari Krishna Nair is a panel member. We came to a consensus-derived decision that a surgical wound complication is defined as a disruption to normal incisional wound healing following surgery. So it's fairly straightforward. It's a term that it can includes several more specific issues related to wound complications after surgery. It's an umbrella term that encompasses more specific diagnoses such as surgical site infection, surgical wound dehiscence, hypergranulation, peri-wound maceration, scarring, and medical adhesive related skin injury, or MASI, which is getting some attention in the wound care field today. So before we dive into the definitions, we need to look at the principles of acute wound management. And these have been set in time, promote healing by intention, primary intention, assess and reduce risk of complications, protect the incision site, use aseptic technique at all times, promote patient recovery and well-being, and early identification of complications is key to prevention and management. When we look at Halsted's surgical principles, and some of you may recall this from your medical or even nursing training, we can come back to basics when it comes to surgical wound management. And Halsted proposed in the 1800s, early 1900s, several principles that still remain to this day. Most importantly was the gentle handling of tissue, meticulous hemostasis to be maintained during the procedure, preservation of blood supply, strict aseptic technique, minimum tension on the tissues, accurate tissue apposition, and the eradication of dead space. And these surgical principles are still in place to this day. But when we do have wound complications, we need to ensure that we're defining them and classifying them correctly. So when we are determining what is wrong with the wound, we're making an accurate diagnosis based on a system or a definition that is consistent and is used globally. The most common definition for surgical site infection is the Centres for Disease Control, used in their prevention of surgical site infection, the CDC work, which was done in the early 80s. Now, to classify a wound that has a surgical site infection, there's two different types, there's three actually. You've got superficial, deep, and organ space infection. And for some of you, you're familiar with these definitions. But the infection needs to incur within the 30 days following the procedure and involves skin and subcutaneous tissue. Purulent drainage needs to be present, and interestingly, according to the CDC, this is with or without laboratory confirmation. Organisms isolated from an aseptically obtained culture or tissue fluid from the incision, and at least one of the following symptoms or signs of clinically diagnosed infection. So pain or tenderness, localised swelling, redness, heat at the incision site. If the incision is deliberately opened by the attending surgeon, it's a bit of a different situation. Now, with the CDC definition, you'll notice point 4, diagnosis of a superficial SSI is to be made by a surgeon or attending physician. When we look at the second compartment of a surgical site infection definition, we're now looking at deep or organ space. So this is where the tissues have completely separated. You can see muscle, fascia, or even organs. Again, it needs to occur within 30 days. Of the operation if no implant is left in place, or within a year. So I do know that they have extended that out to 90 days, the CDC, so that incorporates any implant procedures. Again, purulent drainage from deep from within the incision, but not from the organ space component. It's spontaneously dehisced or opened by a surgeon, and following signs and symptoms, so fever, again, localised pain, tenderness, erythema, and so on. Again, the diagnosis needs to be made by the surgeon or attending physician for it to qualify for a surgical site infection. But what of the economic or the epidemiological burden of surgical site infection? And there's been a number of studies over the last couple of decades that have yielded lots of information as to the conundrum of this particular type of wound. In 2002, it was estimated the incidence rate of SSI was 4.5%. So that works out to around 1,000 patient days or 1.7 million affected patients in the US. In the European Union, not too dissimilar, 5.7 prevalence rate. And in Australia, it's the third most commonly reported healthcare-acquired infection. It has been recently published also in low to middle income resource settings that it's as high as 11.8 per 100 surgical patients. So we have an understanding to some extent about the epidemiological background of surgical site infection. But as we all know, there's a dollar cost associated with most things in wound care. So when we look at the global economic burden of surgical site infection, this pictograph explains it quite simply. It gives you an idea of the cost to the acute care setting for managing surgical site infection. So this image will tell you essentially what it costs to manage a patient in the acute care setting. So we have a fairly reasonably good understanding of the economic burden of SSI within the acute care setting. Where it is lacking is in the primary healthcare setting and community nursing setting. And interestingly, I think this is the tip of the iceberg, because when we look at post-discharge surveillance and we look at when the patient's being discharged, they're being discharged a lot quicker nowadays. It is quite possible and likely that the burden of wound management for surgical wound complications falls outside of in the acute care setting and onto primary and community nursing. I asked this question quite a number of years ago and did a piece of research with a couple of professors here, and we had a look at a surgical wound dehiscence here in Western Australia and the cost, time to healing of community nursing. What we found was the cost of managing surgical wound complications post-discharge in community nursing setting was twofold, or twice that of managing patients that didn't have a surgical wound complication. There are some studies coming out of Northern Europe. I know Judith Tanner's done a fair bit in the UK looking at colorectal procedures, and they have also found very similar findings. So we really need to publish our work to tell the story about surgical wound complications in community nursing and primary health. But the impact, the global impact, patients suffer with pain, they have delayed healing, they can't return to normal daily life and have reduced wellbeing. Extended hospital stays for those that are readmitted into the acute care setting and can increase hospital costs by up to 20%. If they're managed in the home or primary care setting, there's quite a considerable impact in terms of extended community nursing visits and the costs associated with that. What we're faced with currently with surgical site infection research globally is that it's difficult to monitor. And the reason being is that we have so many different definitions for surgical site infection. We have reporting definitions, we have clinical definitions, and no two definitions are the same. So when we're trying to pull research, epidemiological or translational research is extremely difficult because we're not comparing like with like. The other issue we're faced with is limited discharge surveillance reporting. And there are now a number of systems globally out there that are starting to be implemented into practice where we can track and monitor surgical wound complications post-discharge. So we can also look at prevention. How do we prevent surgical wound complications? Very good question. What we need to do is put the patient at the centre of the equation. So not only does the patient undergo surgery, there's many different phases of the patient's surgical journey that we need to traverse when we're looking at trying to prevent complications. So we look at the preoperative phase, we look at the intraoperative phase, and the postoperative phase of the patient's surgical journey. And this can be represented as a Venn diagram. So if we can interchange surgical wound dehiscence with complications, we have technical issues. So that's things that are related to what's happening in theatre. We have disrupted healing factors. So they are pre-existing comorbidities, nutrition and things like that. And then we have what's actually happening on the microscale. So what is happening with the wound bed interface? Again, a Venn diagram can show you the preoperative, intraoperative and postoperative phases of the surgical journey. So when we're looking at assessing a patient's risk of surgical wound complications, we can use this as a conceptual framework. And if we put that in a diagram with the patient at the centre, you can see the number of factors. There's quite a suite of factors that are known to impact on a patient's post-operative wound healing outcome. We can look at what's happening in theatre. So if we look at mechanical factors such as the class of surgery, whether it's clean, contaminated or dirty, so it's the class of the surgery, the method of closure, suture versus staples, glue, things like that, trauma due to injury or fall, surgeon experience. Are we dealing with a senior consultant or a junior RMO who's in training? What's happening at the wound bed interface? Is there seroma or hematoma occurring? Has the patient had a previous surgery in the same anatomical location? And how does that impact the skin integrity? Because we know that an incision line never returns to full tensile strength. It only returns to 80%. So if we're going close to that incision line, we could be already dealing with compromised skin tensile strength, increased tension at the suture line. What things can we use to offload the tension at the suture line? Obesity, high BMI, so the physiological aspects. So there's the pre-existing comorbidities that may be modifiable or non-modifiable risk factors. Does the patient need to lose a little bit of weight prior to surgery? Does the patient need to quit smoking? There's a number of level 1 randomised controlled trials that have demonstrated efficacy in compared to those patients that don't smoke compared to those that do. Within a 2-week time frame, cessation of smoking prior to surgery reduces your risk of a surgical site infection. Diabetes, the role that diabetes plays in reduced oxygen tissue oxygenation, the impact on homeostatic systems, other chronic diseases, cardiovascular disease, cardio-obstructive pulmonary disease, peripheral arterial disease, poor nutrition. All of these factors, a lot of the surgeons, you guys already know this, and you are in a way on top of your game. However, the journey just doesn't stop in theatre. If we look at preoperative, we can look at some of these issues that we may be able to control. We can try to control infection and contamination and devitalise tissue. We can look at the oxygenation, saturation and improve that in theatre. Systemic factors that are patient-related, as I've gone through before, smoking, malnutrition, chronic disease, age is also an interesting factor. Psychological stress, we know there is a considerable link between depression, health and well-being in the post-operative period and wound healing, and the extrinsic factors which are related to post-acute surveillance. When we're looking at how we can change things in theatre to prevent surgical site infection or surgical wound complications, there is an absolute mountain of work out there that you can avail yourself. I know there is the Asia Pacific Infection Prevention Control Society that has a guideline available for you. There's the CDC, the UMA surgical site infection document. My personal favourite is the World Health Organization Global Guidelines on the Prevention of Surgical Site Infection. That was published in 2016 with a surgical site infection focus. It is a very rigorous, systematic and methodical review of all the available evidence out there for prevention of surgical site infection. It uses a grade pro methodology approach, which is as a higher standard as a Cochrane review. So if you're trying to implement things in clinical practice and you're looking for evidence-based guidelines, I strongly recommend the WHO guideline. The NICE Institute, the NICE Surgical Site Infection is at a recent update. That's also a comprehensive guideline. There are a number of guidelines out there. The question is, are they evidence-based? And that's the question you need to ask yourself if you're implementing something into clinical practice. So you can avail yourself of a lot of these documents. They're available online, free to download anytime. So we've looked at the intraoperative environment, and now we'll look at post-operative incision management, and this is where there needs to be considerable amount of work done. Obviously, the questions I always get are, what's the best dressing to use? Where's the evidence? Now, interestingly, Joe Dunville's group in the UK did a systematic review, or a Cochrane systematic review, looking at the available evidence for the prevention of surgical site infection using advanced wound dressings. So that's things like basic dressings, hydrocolloids, to film dressings, to hydrofiber. They did a separate one for negative pressure wound therapy. And interestingly, the systematic review and meta-analysis yielded very limited evidence for efficacy in terms of preventing surgical site infection. And there's a number of reasons for this. First and foremost, there is a there is a considerable lack of level 1 randomised controlled trials that have been designed with systematic rigour and academic integrity in this area. For a Cochrane systematic review to provide clinical recommendations, it needs to be able to assess and pull the data of level 1 RCTs. There's simply not enough out there. There is a growing body of evidence, and it's really great to see that in wound care. I think in the last 30 years, it's starting to slowly get there and reach the evidence-based scholarly train of work that, say, other disciplines have, such as surgical research, vascular care, general surgery, oncology. So it's starting to provide evidence to the field in that standard. So the jury is still out. Negative pressure wound therapy, there's a lot of discourse around this type of advanced therapy, and unfortunately there's too many conflicting studies to say one way or the other whether it should be used to prevent surgical site infection. However, when we're looking at incision management, we need to ask ourselves the question, go back to your Holstead principles and principles of acute wound management, and think about the optimal characteristics for post-operative dressings. You want to be able to visualise the incision line with minimal disruption to the incision site and apply the principle of undisturbed wound healing, ideally in an ideal setting. Now, in some cases, that may not be appropriate, so you need to use your clinical judgment in applying the most appropriate dressing that you feel will work. We want to protect the incision site and prevent contamination, so we want to create a closed circuit where we don't want microbes or any bacteria getting into that wound bed interface. And more importantly, we want it to be comfortable for the patient and have ease of removal. So we want to minimise discomfort to the patient when we are removing the dressing. So when complications do occur, there is a number of wound infection assessment and scoring systems available. These two, the asepsis score and the Southampton wound grading system, are the ones that are most commonly used in surgical settings. They're also the ones that are most commonly used in the literature. There are, I know in IWII, which Professor Hari mentioned earlier on, they have a wound infection continuum, and I think that is a course for much debate. It's more of a theoretical discussion rather than a clinically based assessment tool. And I think most of you will find that in your surgical training, you would have come across the asepsis or the Southampton wound grading system, very easy to use. And they provide that level of information that allows you to make an objective assessment in terms of what that wound's looking like, and the score most likely being it's an infected wound or not. Nothing beats microbiological testing and pathology. That is the gold standard, and where possible, it needs to be implemented or engaged and also recorded in the wound care notes. One of the big issues we have in wound healing is talking about surgical wound dehiscence when there isn't a confirmed infection. What do I mean by that? In wound healing terminology, we have many different grading or classification systems. If you think about, we have pressure injury or pressure ulcer grading systems that we use in a clinical setting. We also have a skin tear grading system that we can use with our patients to determine a patient flow of care. But what I've noticed, quite a while back now, there is a distinct absence of a grading system for surgical wound dehiscence. And although we have the CDC definition for a deep or a surgical site infection, we don't really have anything that's specific for wound care terminology that allows us to grade with detail wound dehiscence with or without infection. So what I decided to do was create a system that can be used in a clinical setting and grade it from 1 to 3. However, I decided that it's probably a good idea to share this with an international panel and get some opinion on this one. So, in conjunction with Wounds International and the World Union of Wound Healing Societies, we devised the surgical wound dehiscence grading system, and this is available free online for you. Now, the World Union SWD grading system, which has been adapted from the original taxonomy I published a number of years ago, gives you a very clear definition of surgical wound dehiscence. So we're not guessing anymore. We have a definition for surgical wound dehiscence, and we have a four-graded system in regards to what degree the wound has broken down. So the first degree would probably be equivalent to a superficial surgical site infection. So that's the dermis only, no visible or subcutaneous tissue, right down to 4A, which is a deep or open, quite close to organs, you can see. There is the italicised A, which demarcates the presence of infection. Now, with this definition, you need to confirm the infection through microbiological testing. So you need to partner with your pathology labs or have access to that type of gold standard practice to be able to classify the SWD as either an A or no infection whatsoever. So this is a new system, and it's available free online at the IceCap website or at woundsinternational.com. Now, when we're looking at trying to prevent in clinical practice, it's ideal to have internationally accepted best practice recommendations for early identification and prevention of surgical wound complications. And this was put together by the IceCap panel, and ask Professor Hari any questions. He's also on this panel and co-author of this document. And so what I will do now is go through the 9 best practice recommendations that you may or may not wish to implement into clinical practice. So individual patient assessment should be undertaken as per your local guidance during, remember those 3 phases I talked about, the pre, peri and post-operative periods. And this includes post-discharge. So it's really key to have a multidisciplinary team approach or an interprofessional team approach in the management of this patient, utilising an individualised care plan. So it's not just going from broad spectrum care patient management, it's starting to go to precision or personalised medicine. Local and national SSI policies must be evidence-based and should be adhered to and documented in the patient notes with a seamless flow from discharge to community and primary healthcare settings. So post-discharge surveillance should be mandatory across teams. So it's in the post-acute setting, primary and community nursing, and also within the hospital setting. There should be defined assessment, treatment and referral pathways, and I'm sure that you all have those in place. And that communication between each clinical area that may or may not utilise digital platforms. If one thing COVID-19 has taught us is the accessibility of digital technologies and the ability to be able to communicate very quickly via apps or via other digital platforms that allow free flow of information between patients and also healthcare providers. Prevention and treatment should encompass a multidisciplinary team approach that reflect that patient's surgical journey. So it's the surgeon, attending physician, the nurses, the other healthcare providers, so podiatrists. The team approach is really key here in prevention. If a bacterial cause for an infection is suspected, appropriate investigations should be started to identify the causative agent. And it's usually not just one agent, biofilms and so on and so forth, a polymicrobial. and it's usually multi-species that are involved in some types of infections. And this also brings us to the question of the use of antibiotics and whether you have an antimicrobial stewardship program available where you are, and to ensure that you adhere to your AMS stewardship policies. Novel strategies for patient engagement should be used to aid early identification. So dressings that allow for full visualisation of that incision site, so you don't necessarily need to remove that dressing. You can leave the dressing on for longer to maintain that closed circuit. Telemedicine in remote and rural areas, or even now in city areas with the COVID-19 pandemic. New diagnostic technologies, smartphone applications, and validated fit-for-purpose risk assessment tools can be implemented quite early on in the patient's surgical journey. All surgical wound complications should be documented and reported appropriately and accurately using standardised global definitions. My favourite, Statement 8, further research is required to expand the scientific knowledge in determining evidence-based practice for prevention of SWCs with regards to advanced wound care therapies. As we've seen from the Cochrane Review in 2016, the field of research in this area is starting to grow. It's getting better, but we're still a long way off being able to say with our hands on our hearts that we can be using certain technologies based upon multiple randomised controlled trials that have been well designed and stand up to academic rigour and peer review. Last statement, outcomes including patient reported outcomes must be tracked, documented, reported where possible, and publish or perish. And this will enable us to maintain and also draw a global understanding of the prevalence of surgical wound complications without getting the message out there, without documenting, without publishing. We don't really know what is happening out there and how we can prevent and also measure outcomes in terms of whether a therapy is effective or not in prevention and management. And we're very closely getting to the end of the presentation. And I just wanted to sort of get you to reflect upon prevention and management of surgical wound complications as more than just the latest and greatest dressings. And I can sort of draw your attention back to that Venn diagram about the patient's pre-existing comorbidities, their lifestyle factors and surgical factors, and take a holistic perspective, putting the patient at the centre. And I know that you all do that, and taking a multidisciplinary team approach in prevention and management. And it's all about the patient, of course. But I'd like to take this opportunity to say thank you again to Lincoln University, Professor Sandeep and Professor Hari Krishnan there for the opportunity to share this with you, and happy to take questions. Thank you.
Yes, participant can unmute themselves and question. Please feel free. Thank you, madam, for your nice presentation.
Thank you.
Anybody have any question? Please feel free to ask. You can unmute or you can write in chat box.
I think everyone's gone to sleep. Afternoon tea time.
So, madam, you nicely describe about the grading system to full, what you call the prevention of surgical wound complication, everything in a nutshell. Means vivid. If you going to talk, means it is a huge area, vast area.
It is.
Thank you, madam.
It's quite a complex area, and I'm sure the surgeons in the room would agree with me on that one. And it's not just vascular surgery, general surgery, orthopedic surgery. It spans the entire gamut of surgery, and it's not about the surgeon. It's not about just one factor. It's multifactorial, and there's a lot of programs out there now that are seeking to improve outcomes for patients in that post-discharge surveillance period.
Madam, one thing that I want to ask, that if we have we use betadine or something for the wound when surgery done, so any idea about if we use like that oxygen therapy or any other thing during the surgery?
That's a really interesting question, and huge caveat here. I'm not a surgeon and I'm not clinical, so I won't be dispensing any clinical advice. What the evidence has shown is that doing something is better than doing nothing, and quite often the post-operative skin prep period is quite good in using a povidone iodine or a betadine. In terms of using topical oxygen therapy, I am not aware of any studies that has been done out there. Perhaps Hari, if Hari is still with us, Professor Hari.
No, he went some urgent work.
Yep, I'm here. No problem.
Oh, okay. Back.
Professor Hari, are you aware of any studies that have been done with, say, Natrox or Epiflow with surgical wounds?
Natrox, I think so far, what do you call this? Nothing on surgical wounds so far. Because the thing is, for surgical wounds, it's already primary closure. So there is no, what do you call this, unless you want to use it for delayed closure or whatever, yes. But you still have to clean up the whole thing and try to, what do you call this, done. But I think not actually, more for secondary wounds only.
Yeah, so it's more for wounds that have become chronic.
Yep.
Would you say? Right.
And the latest thing is like, hard to heal, complex, all the different new wordings for what do you call this, chronic wounds. So
that's right. I think we've got a question here from Rachel. What are the common modalities used in primary care for surgical wounds in clinical practice in Western Australia? That's a really great question. I've got a little bit of knowledge on that one. Whatever they have in their cupboard, to be honest. It can range from film dressings to foam dressings. Interesting in primary health care, when we're looking at the patient attending their general practitioner to look at their wound, it's quite often the practice nurse who looks after the wound. So the GP will say, okay, you've got an issue here, pop off, see the nurse. And it really depends upon the level of education with that practice nurse. So some practice nurses might be well versed in advanced wound dressings and they may implement silver type dressings, or they may assess the wound and say, well, there's a lot of exudate, we might trying this, send the patient home with some dressings, whether it be a foam dressing or sometimes even a simple gauze is used. No two practices are the same, and there doesn't seem to be a standardised practice, to my knowledge, across consistently across primary healthcare in Western Australia. So it is very much a hot topic of discussion here in Australia, not just in Western Australia. Thank you for your question.
And Madam, another thing I want to ask, that as Dr. Bhomik, Professor Bhomik, morning telling that what is the psychological support as a nursing personnel. So I want to learn from you that means when 1% of house is affected, so means with the amputated leg or something, then the whole family is having a mental pressure on them, as well as financial and mental. So one person cannot do proper work, he is sitting inside the house. So it is a means mental depression or psychological stress on them. So how, as a caregiver, how we can move out and how we can do on mental health support on this aspect. If you can think and about this, we can work in this line, then it will be good.
I think it's the reality of it. I think you as clinicians actually provide that level of support, even unknowingly sometimes. I think just listening to the patient, quite often them sharing or talking to you about how they're feeling eases that burden. In Australia, we have a system in the primary healthcare setting where if you're diagnosed with a level of anxiety or depression, you can have a certain mental health services provided to you free of charge from the Australian government. So you can seek counselling, and that's a one-on-one, quite a number of sessions you can now have. It's part of a mental health care plan, which is provided by the Australian healthcare system. As clinicians, you've got a lot on your plate. I think just listening to your patients, when you're visiting them in the home, it's probably quite challenging dealing with that situation. But talking with your colleagues as well too, sharing the stories and finding different ways of managing patients that may present different in different situations might also help. But I'm not sure whether you've got a similar mental health care system in your respective regions and countries that your patients might be able to have access to that help them deal with depression and anxiety in relation to their wound healing. So that would be something to check your local services to see whether you'd have access to something like that.
Yes, madam. So any more question from participant?
Yes, Dr. Kylie, I'd like to know what is the best cleansing agent or a solution that helps in wound healing? Thank you.
The best cleansing agent, okay. There is a systematic review that's been published quite a while back, and what the cleansing, what they had shown was there's not enough evidence to demonstrate efficacy with modern cleansing agents compared to sterile water. So essentially, sterile water seems to be the way to go, where you can have access to that. But that doesn't mean that cleansing agents don't do the job. What it means is that we don't have enough level 1 randomised controlled trials, enough research for us to pull the data to say, yes, it's effective when we have an intervention and control group. So be wary of what company representatives are telling you. If they say there's plenty of evidence, then question the evidence. Is it a case series? Is it a retrospective medical note audit? Or is it a prospective randomised controlled trial? And make the call for yourself using your clinical judgment.
Thank you.
Thank you for the question. I don't think any more questions, no.
No. So we can end here, I think, today's session. Dr. Hari sir, we can end. Hamui, everybody participant. So we are ending today's session.